Hello, everyone. Thank you for joining us today for our webinar entitled MIPS 101, an introduction to the merit-based incentive payment system for new participants. Today's presenter is Bruce Mackey, Alterum's Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. A PDF copy of today's slides can be downloaded right now from your GoToWebinar interface. We will be keeping everyone muted during today's presentation. If you have a question, please type it into the questions box in your GoToWebinar interface, and we will address it during the Q&A. Because of the large number of attendees for today's webinar, we may not have time to answer all of the questions. If we do not address yours during today's broadcast, you will receive an answer through email. Also, a link to the recording of this presentation will be available soon on the homepage of our website at www.qppresourcecenter.org. Today, Bruce will provide a brief overview of the Quality Payment Program and its two paths of participation. From there, he will spend the rest of his time discussing the various aspects of the merit-based incentive payment system, including general timelines, eligibility and exemption criteria, reporting options, important information in each of the MIPS performance categories, as well as the annual performance threshold and subsequent payment adjustments. Following the presentation, he will take time to answer any questions posed by the attendees. Please note, the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you everybody for joining me today to go through the MIPS 101 slides again, an introduction to the MIPS program. This is an ideal presentation for new participants, but I know that many of you that have already been participating for years are likely to pick up some new information out of this as well. So why don't we dive right in? I've got a wealth of information that I hope to be able to cover here in the time that we have allotted today. All right, so we're going to start from the very top and talk about the program in general. So we have the Quality Payment Program. It was something that was started in 2017. It was a function or a portion of the MACRA, or Medicare Access and Chip Reauthorization Act of 2015. It required CMS to, by law to implement a new incentive program. That program is called the Quality Payment Program, and it provides these two different tracks that you can participate in. On the one hand, we have the MIPS track, and that's where we're going to be spending really all of today talking about that track. That is where we see the majority of participants right now. But there is this other track that a small portion of you are in, and it's growing each day as you're kind of bridging that gap from the MIPS track over to what is called the Advanced APMs track. And really, overall, what we're trying to do here, what CMS is trying to do is, one, the Quality Payment Program repealed the SGR, the Sustainable Growth Rate formula, which was really just a disaster, and it was getting worse all the time. It was going to significantly cut Medicare payments, which is really going to devastate the Medicare provider community. So we got rid of that, thankfully, and now we have the QPP. And really what we're trying to do here is get rid of fee-for-service payments. So over time, for decades and decades now, that has been the primary way that CMS has paid for the services that all of those Medicare clinicians are providing. So you bill a code, you get a reimbursement. But there was no distinction between great doctors and maybe less than stellar clinicians. So they were all getting paid the same amount for every service. So we're trying to get away from fee-for-service and instituting this new program that is trying to find a way to distinguish between high-quality, low-cost providers and the opposite, those low-quality, high-cost providers, and starting to penalize those low-quality, high-cost providers and incentivizing the high quality, low cost. So we're shifting that model, getting away from fee-for-service payments. So over time, we're going to shrink fee-for-service payments to be the absolute smallest way that CMS is paying for their services. So I found this very rudimentary diagram as a good way to kind of conceptualize what we have here with this new program. The very top, we have MACRA. It was a massive piece of legislation. It had a whole bunch of other stuff contained within it as well, but it also brought us the Quality Payment Program. Then within the Quality Payment Program, we have those two different tracks, the merit-based incentive payment system, and then these alternative payment models. Under APMs, there's a couple of different types of APMs, right? So we have the advanced APMs, which is really that other track. And then we have these non-advanced APMs. The distinction between those two is it really comes down to risk. Most of the alternative payment models out there don't have enough risk built into them, meaning there's not that two-sided risk where if the APM doesn't perform well, it has to pay money back to CMS. Most of the APMs, and when you see APM, most traditionally we see those as being ACOs. Most of those ACOs don't have enough risk built into that model. It's only a one-sided risk, not two-sided. And so those that are APMs that don't have enough risk built into them are not advanced APMs. They're really called MIPS APMs in this program. And so what we really end up with here is really almost a third track. I think it actually makes sense to move this box and put it right here, because when you're in one of those MIPS APMs, which is the majority of you that are functioning within and are participating in an ACO right now, you're sort of bridging the gap between the two main tracks. You're not just in the MIPS track, although those clinicians that are in those MIPS APMs are participating in MIPS, but they're not just solely in that advanced APM track either, because they don't have enough risk built in. So they're kind of bridging the gap between those two models, where you're still participating in MIPS and getting scored and having your reimbursements adjusted as a function of that performance. But you have some fantastic benefits coming from that participation in that MIPS APM, in that ACO. So really the MIPS APM almost creates this third track that sort of bridges the gap between the two main tracks, MIPS and APMs. Overall, the QPP has a bunch of goals that they have baked into it. They're hoping to achieve with this new program. Improving beneficiary outcomes, reducing burden on clinicians. I'll tell you right now, the QPP is not reducing the burden on clinicians. Hopefully over time we will start to see that, but I think CMS has a long ways to go before we can actually say the QPP is reducing burden. Right now I would say it's doing the polar opposite. Increasing the adoption of advanced APMs, maximizing participation, improving data and information sharing, ensuring the operational excellence in program implementation, and then delivering the IT system capabilities that meet the needs of users. We'll see over time as CMS is able to achieve these goals. I think they're making some headway on some of them, but I think we're going to need to see some additional changes in the QPP if we're going to realize all of these goals. Just my personal opinion. So what is MIPS? We've got it's the merit-based incentive payment system. It really combined a bunch of these legacy Medicare Part B programs that we've been participating in for years now, kind of baking them into this new single program. It took the Medicare EHR incentive program, otherwise known as Meaningful Use. That program ended in 2016, and so the components of that program have now been baked into MIPS. We have the PQRS, or Physician Quality Reporting System. That also ended in 2016. The elements of that in terms of quality reporting have now been pulled into this program. And it also did away with the value-based payment modifier and pulled the cost components of that program into this new program called MIPS. So within MIPS, we have 4 performance categories that you must participate in if you're going to fully participate. If you're going for broke, trying to get the best MIPS score you can, you're going to want to participate in all 4 of these categories. So we have the quality category, which is really just the retooling of the PQRS program. We have the cost category, which again is just that retooling of the value modifier program. We have something called promoting interoperability, or PI. It's really just what's left of Medicare Meaningful Use. It is vastly different from what Meaningful Use used to look like. They've stripped away a lot of the measures and objectives, and we're left with just a handful here. But really, promoting interoperability is just Meaningful Use sort of undergone a major retooling. In the beginning of this program, that category was called ACI, or Advancing Care Information. About a year ago or so, CMS made a naming change to that category. It is now known as Promoting Interoperability. And then we have something called improvement activities as well, which is, was a new category when the program started in 2017, but the activities contained within came from the PCMH model, the patient-centered medical home. So the activities are generally not new to very many. So what you're trying to achieve here through that performing in each of these 4 performance categories is getting the best MIPS final score. So each of those performance categories contributes a certain percentage of that MIPS final score. So 100% or 100 as a score within MIPS overall is perfection. You're doing as best as you possibly can. And so the points from each of those performance categories get added together to feed into that MIPS final score. Then that MIPS final score gets compared to the annually set MIPS performance threshold to determine if you receive a positive adjustment, negative adjustment, or neutral payment adjustment to your Medicare reimbursement rate. MIPS is a budget neutral program, and I'm going to talk about what that means and the ramifications of that a little bit later. So we have a MIPS general timeline here. For those of you that are new and just trying to get off the ground and kind of understanding what that participation means and how and when you're going to attest. So we're in that performance period right now. It opened on January 1st of 2019. It's going to go through the whole calendar year. After that, we get the submission period opens up. That's generally around the first 3 months of the following year. So in the beginning of 2020, we'll have the data submission period will open up, and we'll have at least 3 months to get the data in. CMS extended that deadline a little bit for this past year. Not sure if they will for next year, but they let us still submit information into early April. They may do that again in 2020. We will see. Following that, CMS is going to take a few months to process all of that feedback and all of the data that's been submitted. And then usually around the summer, around July or so, we'll get those. July of 2020 is when we'll get all of your feedback reports and your final scores and everything to determine how you did in 2019. And then, as we have seen with the legacy programs that this program replaced, there's generally always a 2-year lag between the performance year and the payment year. So whatever happens in 2019 is going to generate a MIPS final score that gets compared against the threshold, and hopefully you'll do well enough to earn a positive adjustment. And if you do, that starts to be paid out on each claim beginning 2 years later. So the 2019 performance year affects your 2021 payments. So how does CMS determine if you or your clinicians are included in MIPS for this performance year? Well, they start by identifying if you're a MIPS eligible clinician type, and I will talk about in the next slide kind of who those folks are. Then they look to see if those folks exceed something called the low volume threshold, and I'll expand upon that in a moment. And if you meet or exceed all 3 elements of that low volume threshold, and you're one of those MIPS eligible clinician types, you'll find that you are required to participate in MIPS to avoid a penalty. There's a flip side of that coin who's exempt from it. If you are a newly enrolled Medicare provider, meaning you've just gotten credentialed to accept Medicare patients in 2019, you're exempt from participating this program year, but you may find yourself getting pulled into that mandated participation next year. If you're below that low volume threshold, you're excluded from MIPS. Or if you're in the other track, right? We're talking about the MIPS track right now, but we have that other track called advanced APMs. If you're significantly participating in that advanced APM, then you are excluded from MIPS participation as well. So what is a MIPS eligible clinician? There are both physicians and non-physician clinicians who are eligible to participate. CMS defines who the clinician types are each year. We saw it expand significantly this year from previous years, and we're going to continue to see additional provider types get pulled into this program. Remember that earlier slide where I said we're trying to shrink fee-for-service payments to be the absolute smallest way that clinicians are being paid for their Medicare Part B services. So that means each year I think we can expect additional provider types to be pulled into this program. And I will show you who they are for this year in just a moment. So being identified as one of those MIPS eligible clinician types then is that first step in determining whether you're required. If clinicians who are not considered that MIPS eligible clinician type are excluded. So here's our MIPS eligible clinician types for 2019. We've had physicians, PAs, NPs, clinical nurse specialists, and certified registered nurse anesthetists since the beginning, since this program launched in 2017. Everyone else listed here, from clinical psychologists to physical therapists, occupational therapists, speech pathologists, audiologists, registered dietitians, or nutrition professionals, they're all new to the program now in 2019. So as a reminder, CMS, the definition of physician is, that's an umbrella term that includes a lot of other provider types. So it's not just your MDs and DOs, but also doctors of dental surgery, dental medicine, podiatrists, optometrists, and chiropractors. Those are all deemed physicians in CMS's eyes, and then are all eligible to participate in this program. So I've talked about the low volume threshold as being one of those criteria that you have to overcome in order to find yourself your participation being mandatory this year. So it's that second step, now that we've determined who those provider types are, that we then look at the volume of Medicare services being provided by that clinician. If they see enough Medicare patients and bill enough to those Medicare beneficiaries, then they will overcome that low volume threshold. CMS conducts MIPS determination periods where they look to see if those clinicians exceed the low volume threshold criteria. If you exceed all three elements, and I will talk about what those are in a moment, then you're included in MIPS. If you do not exceed all three of the criteria, then you're excluded from MIPS. So they look at two different determination periods to measure that Medicare volume. There's the historical period, which has ended for this program year. That ran from October 1st of 2017 through September 30th of 2018. If you're excluded from this initial run, you're going to maintain that status regardless of what they find in the second performance period. So if you look at your participation status right now for 2019 and it says that you're excluded, they have determined that exclusion based on that first historical period, and that's not going to change. But the flip side could be true. If you find that you were included in that initial look back period, you may be then excluded if you fall below the low volume threshold in this second determination period, which we are still in the middle of. That started on October 1st of 2018 and runs through September 30th of this year. So you may find that it says that you're included right now in the participation lookup tool, but after they load all the new data later this year, if your Medicare volume has slacked off since that historical period look back, you may find that you are then excluded later this year. So here are the three elements to the low volume threshold. And if you are at all familiar with the program, you're going to recognize bullets 1 and 2 are what we have had previously. There is now a third element that they've added for 2019 as well. So element 1 is you have to bill more than $90,000 a year in allowed charges for covered professional services under the PFS, and you also have to furnish covered professional services to more than 200 Medicare beneficiaries. And now this new third element, you also now have to provide more than 200 covered professional services under the physician fee schedule. CMS defines a covered professional services as a single claim line with a positive charge. That would, so you have to have at least 200 of those billed throughout that determination period. So all three of these elements have to be true. If any one of these is not true for a clinician, that would knock you out of that mandatory participation status. There's two different ways that you can look up that participation or the program eligibility. You can go to the link that's on the slide right now. QPP.cms.gov is CMS's main QPP website. There's a wealth of fantastic information there. There's this participation lookup tool there, a lot of fantastic resources. And so I highly encourage, if you're not familiar with that site, go there, click around. You'll definitely want to check out the participation lookup. But the limitation there is the one on your screen now, the kind of main lookup tool, only allows you to put in one NPI at a time. And when you do that, it's going to show the participation status for that one clinician across all locations that they work at. So if they're billing from more than one tax ID, you're going to see that status displayed, or that eligibility displayed separately for each one of those tax ID numbers. There's a second place you can go to look at all of your clinicians all at once and just look at the information that's relative to your tax ID. It's actually at the same website, and it's through the data submission portion of that website. So if you go to qpp.cms.gov, I think it's the far right upper right corner. I think it says login or something like that is the icon. If you go there, that's the actual data submission tool. Log into that system, and that is going to display the eligibility information for all of your clinicians, and it's not going to have any information outside of your TIN. So you can see all of your the status of your clinicians all at one time. So there's a few different reporting options. If you find that you're required to participate in MIPS, you can participate in a couple of different ways. You can participate at the individual level. So under that model, each NPI and tax ID is seen as a separate program entity. Whatever you may find that a clinician is exempt from participating at one tax ID, but might see that their participation is mandatory at another tax ID. So each one of those tax IDs generates that separate eligibility. You can also participate at the group level. So a group is defined as 2 or more clinicians who have reassigned their billing rights to a single tax ID. So in that model, you are consolidating all of the data from all of the clinicians in your group and submitting a single data set. Relative to that low volume threshold, it remains the same at that group level. So those same 3 elements are exactly the same for the group, only you're now bumping the entire group's Medicare volume against that low volume threshold and pulling the whole group in, eligibility in. If you are in any type of ACO, you are locked into group participation. You cannot participate at the individual level. And your group then is actually a super group. It encompasses all of the clinicians that are participating in that same ACO. That's what bullet point 2B is. So as an APM entity, that alternative payment model entity in this regard would be that ACO. And so you are locked into group participation. So the entire ACO is going to get a single MIPS score based on all of the performance of all of the clinicians, and it's going to roll up to that ACO level, and then all of the clinicians within that ACO get that same MIPS score. There's also something called a virtual group, and it's not a very popular way to participate right now. I think we may see it grow over time. I think the easiest way to describe a virtual group is it's sort of like a mini ACO. So in much the same way that an ACO takes clinicians from multiple tax IDs and allows them to participate in this super group, a virtual group is sort of the same thing. It's made up of solo practitioners and groups of 10 or fewer eligible clinicians who come together virtually in much the same way that an ACO does to consolidate all of their data and participate as a group of clinicians from multiple TINs. So I think I already touched on this. So that low volume threshold, how it applies to groups. If your group contains at least one MIPS eligible clinician and collectively exceeds that low volume threshold, as I mentioned, it's that same criteria, then the whole group can participate together. So note that group participation is always optional. You are never forced to participate at the group level. So that can be a little bit confusing when you go to that participation lookup tool. you might see that a clinician, the individual status is grayed out, meaning they're not eligible to participate at the individual level, or at least their participation is not mandatory at that level. But then the group option will be lit up green, which indicates that the group qualifies to participate in MIPS altogether, collectively. That's always optional. You never have to participate at the group level. But if the group opts to participate at that level, then all of the clinicians participate in that option, even if they are exempt at that individual level. So group is always optional. So if your group does not exceed all three criteria, then the group would also be excluded from MIPS and does not need to submit any performance data then. So what happens if the clinician or group is excluded but still wants to participate? There's a new option here that I'm pleased to see CMS bring in. So there's two different options really to participate if your clinician or group is excluded. The first one we've had since the beginning of the program, and that is to voluntarily participate. So you don't have to participate, or you're not eligible to participate, but you want to submit that data to CMS anyway to receive performance feedback. You're not going to receive any MIPS payment adjustments based on that performance, but that data is still going to be publicly available on what's called the Physician Compare website. So if you didn't already know that, CMS is going to be posting all of these MIPS scores on the Physician Compare website, which then allows patients to shop for clinicians that are high quality and low cost. That would be a reason to potentially voluntarily participate, where you're not going to get any payment adjustments, but if you've got great scores, you're earning a good MIPS score, it might make sense to voluntarily participate so that you can get that data also displayed on that Physician Compare website, so that when patients are shopping around, they get to see how awesome you are. So we have a new option then for 2019 called opt-in. It's a little bit different. So if you are a MIPS eligible clinician type and you meet or exceed at least one of those three low volume threshold criteria, you're now going to be able to opt in to MIPS participation. That's very different from voluntarily participating. The main thing here is if you opt in, you're going to be subject to the MIPS program rules and the subsequent MIPS payment adjustments. So I think this is a great option. We don't have enough information on how to do this yet. There is a fact sheet you can pick up if you want to learn a little bit more about opting in, but the actual mechanism for opting in is not live yet. I think we will see that very soon. I know CMS is working hard to get that built in. I suspect we will see that option within the data submission portion, that kind of second place I told you you could go to look at your eligibility information just for your TIN. I'm almost positive that's where we're going to see the opt-in option come as well. Details are still forthcoming. So just note that when you opt in, you will be subject to the payment adjustment. So don't opt in if you've got a really terrible MIPS score. You're really only going to want to opt in if you're going to earn a great MIPS score, which is going to translate to a bump in your Medicare reimbursement rates. Also note that once you make that determination, you cannot revoke it for this program year. So be sure that when you opt in, you really want to opt in because you're going to be locked into it. So you might want to have a sense of how you're doing in the program before you do that, because you wouldn't want to opt in and then take a penalty as a result of that. So I already talked about the participation lookup tool and the second place that you can also look at all of that information all at one time, just for your tax ID. So what happens if I'm associated with multiple practices in the lookup tool? So I already talked about that each TIN and NPI combination is seen as a separate program entity. So you're going to receive a payment adjustment based on that TIN and NPI combination where the low volume threshold was exceeded. And then any associated practices that did not exceed that low volume threshold or were otherwise excluded would not receive that payment adjustment. And so what we'll see if your clinician is working for multiple organizations is that they're going to end up with a different MIPS reimbursement rate at each one of those tax IDs. A little terminology I want to introduce you to. This is a little bit new for 2019, some newly finalized terms. We have something called, and this is all related to the quality performance category. We have the collection type, which is a set of quality measures with comparable specifications and criteria. So we look at those are such as electronic clinical quality measures, MIPS clinical quality measures, QCDR measures, Medicare Part B claims measures, CMS web interface measures, which incidentally is how the ACOs are reporting that quality data. Then we have something called the submission type. We used to call these a submission mechanism in the past. We now have a new term for submission type. And this one is really important to the quality category. And I'm going to expand upon this quite a bit and why this is a vital thing to keep an eye on. And this single choice of your submission type, which really just denotes the route that your data is going to take to get to CMS. It's how are you getting your quality data to CMS? That the route that you take makes a massive difference in your quality category score. Stay tuned. In just a few slides, I'm going to expand upon that quite a bit. And we also have the submitter type. So the data submission options are a little bit different between individuals and groups. We're looking at the options for individuals right now. And as you'll see, there's some differences as you roll between those different performance categories. So for quality reporting as an individual, you can submit that data direct. Direct is referencing your EHR, your vendor submitting that data on your behalf directly to CMS. You can log in and upload your data, in which case you are getting a quality data file from your vendor, and then you're going to log in to that QPP website and upload that file. And then you can do, if you're a small practice, you can still do claims-based reporting. So if you don't have an EHR, that's probably the way you're getting your quality data. It is now, as of 2019, restricted to small practices only. A small practice is defined as 15 or fewer billing clinicians. So it's not just looking at your MIPS eligible clinician types. It's really looking at anyone in your TIN who is billing Medicare. If you have more than 15 people in your practice billing Medicare claims, you are not able to do claims-based reporting anymore. It's only available to small practices. The cost category has no data submission requirements. All of that comes from administrative claims. Then we see the improvement activities and promoting interoperability categories have the same options, where you're going direct, where again your vendor is submitting that data on your behalf for those two categories. You're logging in and uploading. These ones actually have login and attest, where you can actually just log into that QPP website and attest to those activities and attest to the different performance measures within the PI category as well. A little bit different for groups, which you can look at here. Groups, if they're large enough, have another option for quality data. It's called the CMS web interface. That is how your ACOs are submitting the quality data to CMS on your behalf. But you can also, groups can also be scored on Medicare Part B claims. That's also new. It was previously only eligible and only an option for individual clinicians. Now those small practice groups can also do Medicare Part B claims. So now let's dive into the actual performance requirements of the program and what exactly do you need to do to participate. So we'll look at first the different performance periods. So performance period is that length of time that you or the group are required to report data for a specific MIPS performance category. And it's a little bit, you can see it's not all the same across all 4 performance categories. So you need to report for that minimum performance period. For quality and cost, the minimum is really the whole calendar year anyway. So it's a full 12 month of data. So whatever quality measures you choose to report on, you're going to measure that data for the entire performance year of 2019 and then submit all of that 12 months of data all at once. Claims, CMS is going, or cost, CMS is going to look at those claims for the full calendar year to award you a cost category score. And improvement activities is a 90-day reporting period. So what that means is you are attesting to the fact that whatever activity or activities you are attesting to, you have had them implemented for a minimum of 90 continuous days in the calendar year. Promoting interoperability is also 90 days, and that is a minimum performance period. So don't necessarily just lock yourself into that 90-day reporting period. It often can make sense to extend that reporting period beyond 90 days. You can report for 91 days, 107, or the full 365. It's really your choice, as long as it is a minimum 90 continuous days. It often will make sense to extend that reporting period so that you can do better on the measures. So you're going to want to ensure that you're capturing every possible point that you can in the PI category. You can do that by manipulating that performance period. You may find that extending it a little bit picks up a few more numerators and gets you a better score. So don't limit yourself to just 90 days. If you pull a 90-day report and you're not maximizing the PI reporting category, performance category, either change that 90-day period or extend that 90-day period to include additional days that will do better, that you'll get a better PI category score. So you saw this, a preview of this, the performance category weights, as we talked about on the front end of this presentation. Each one of those performance categories contribute to that MIPS final score, and each one of them are weighted a little bit differently. So in the quality category, this year it is worth 45% of the MIPS final score, so nearly half of your final score comes out of the quality category. Cost is worth 15%. We're going to slowly see cost increase each year until quality and cost are worth 30% each. So by 2022, we should see quality worth 30% and cost worth 30%. This year, it's only worth 15%. Improvement activities and PI have not shifted from last year to this year, and I don't think we will see those shift at all. I think for the long term, improvement activities is going to continue to be worth 15% of your MIPS final score, and PI will continue to be worth 25% of that score. All right, we're going to dive into each one of the performance categories and give you some information in each one of them. We're going to start off with quality because it is worth the most of your the most points. It's also the hardest one. So you'd really need to be focusing a lot of your attention in the quality category. If you've got limited resources and limited time, focus them in quality category to make sure that you're maximizing this. There's a total of 257 quality measures that you can choose from, although that is dependent on that submission type. Remember, that submission type is how you're going to route that data to CMS. Not all of the 257 quality measures can be used or can be submitted via all the submission types. In fact, if you're reporting through your EHR, at most your EHR is going to be able to offer you 53 out of those 257. But you can kind of piece those together this year and use the different submission types to your advantage. If you're going to fully participate in the program, you're going to select and report on at least 6 individual measures. One of those 6 needs to be an outcome measure or a high priority measure if an outcome is not available. If less than 6 measures apply to the clinician or the group, then you're going to report on each applicable measure. I am told that CMS will trust your judgment on what is clinically relevant to your practice. So I know some specialties have difficulty finding clinically relevant measures. If you can only, out of that 257, if only 3 of them are clinically relevant to you, you can just report on those 3, and CMS is going to score you relative to your performance in what is clinically relevant to you. And I am told that CMS won't get into any arguments with you to say, well, what about these other measures? We think they're clinically relevant to you. You get to make that determination, and CMS will trust your judgment on that. So those specialty providers often have trouble finding a solid 6 clinically relevant measures. They have tried to, CMS has tried to help a little bit by providing what is called a specialty-specific measure set. You can navigate to those through that main CMS QPP website. But just note that these are rarely the best option to only report on. Through our own data analysis, we have found that in almost all cases, these specialists still do better by taking a more a la carte approach to measure selection. Everybody can report on any one of those 257 quality measures. So you're not relegated to just your specialty measure set. And in almost all cases, you're going to find that you might use that specialty measure set to point you in the right direction to some clinically relevant measures, but you're still going to do better if you branch off and pull in some additional measures to complete your 6 measures. So in almost all cases, we see that working out better for the clinicians. So then depending on how you perform in that measure compared to that measure's benchmark, you're going to earn anywhere from 1 to 10 points for each one of those quality measures. I've got some resources there to get you started, including the fact sheet, and then some really important information on the benchmarks. And I'm going to expand upon those benchmarks in a moment as well. There are bonus points available. CMS wants your data. So while you submit 6 that will get scored by that performance and will contribute to that quality category score, if you over-report and send additional measure data to CMS, you're going to earn some bonus points. This is a key way to get a better quality score. Ensure that you're maximizing all the bonus points that you can. So you can get 2 points for additional outcome or patient experience measures after that first required outcome measure is submitted. You get an additional point for other high priority measures that you're able to submit. You get a point for each one of the 6 main measures that are submitted using electronic end-to-end reporting. What that denotes is, if you look at those different submission types, some of them are electronic reporting, meaning there's no human intervention there. There's no opportunity for a human to mess up or change the data or whatever, fudge it, make a mistake, whatever it is. But some of the other ones, like EHR-based reporting, where your vendor is submitting it right to you, or you're getting a file from your vendor and you're uploading it yourself, that's called electronic end-to-end reporting, and you get some bonus points for that. So claims-based reporting, on the flip side, would not be electronic end-to-end reporting because that is a very manual process. So your claims-based reporting will not earn you those bonus points, but something like EHR-based reporting will. And then within this category, we get an automatic small practice bonus of 6 points added. So as I already mentioned, that small practice definition is 15 or fewer billing NPIs in your TIN. If you are a small practice, you will see CMS automatically add a bonus of 6 points to your quality performance category. In previous years, if there was a small practice bonus as well. Last year it was 5 points, and it was added to the MIPS final score. They've made a slight change here for this year where they've boosted it to 6 points, and it is being added to the quality performance category instead of the MIPS final score. We also have something called data completeness that you have to be aware of and ensure that you're not violating the minimum threshold there. So data completeness, CMS checks to see if you or your group have submitted data on a minimum percentage of your patients that meet a quality measures denominator criteria. So in 2019, this has gone up a little bit. It's 60% for data completeness. You have to make sure that you are submitting the quality measure data on at least 60% of the patients to which that measure applies. So measures that don't meet that data completeness criteria will then only earn 1 point unless you're in a small practice, in which case the floor is 3 points. A lot of information to unpack here. I want to kind of point you in that direction. Again, this is by far the most difficult category to work through, but it is by far the most important one. So you got to really dive into the quality performance category. Picking your measures is not easy to do. Finding out of the huge list of available measures, finding the best 6 can be a challenge. So you want to pick clinically relevant ones if you can. Look at your overall practice goals and try to align that quality measure selection to your practice goals so that the rising tide raises all boats. As I mentioned, those specialty measure sets are rarely the best option. However, you might look, if you find yourself in that boat where you're difficult to find clinically relevant measures out of the main set of 257, look to the registry option. So a lot of these specialties have a specialty society that is sponsoring a registry. Registries are able to define and get approved their own custom measures. They're called MIPS measures in the program now, these are a great option for specialists with these limited measure options, because it really opens it up, because these specialty societies or specialty registries are getting these custom measures approved, and CMS looks at it and says, you know, that's a great measure, go ahead and use that in MIPS. So it earns a benchmark, you get scored on it, so it really opens up a much bigger playing field for finding some clinically relevant measures. So once you've selected those 6 quality measures, unfortunately, you can't trust the data that's coming out of your EHRs. I know that it seems silly to say that. You might look and say that, well, my vendor is certified, or they're certified even further. They're certified for a particular quality measure. You would think that would mean that the vendors are calculating it correctly. I hate to tell you that's not true. We see a lot of data integrity issues coming out of the vendors. They are just misinterpreting the measures, so they've built it wrong. They've just done something where it's not calculating correctly. Widespread issues. I'm not sure that every vendor or that any vendor has these all 100% right. So I would caution you to not trust that data. You have to do a deep dive into the data coming out of those measures. So look at those numerators and denominators that your EHR is showing you. Look at that denominator set. First, ensure that you're capturing everybody there. But most importantly then, look at those patients that are not appearing in the numerator. You may find that the quality of care was followed. The providers did exactly what they were supposed to do, or the clinical staff, or whatever. And because of a vendor issue, you're not getting proper credit for that quality measure. There's also widespread configuration issues. So this varies from vendor to vendor, but for some vendors, these quality measures don't work correctly right out of the box. There's some practice level setup that has to be done to ensure that it is configured properly and giving you good data. Oftentimes, some codes have to be linked in the background in the setup portion of that quality measure to get it to work right. So again, you may find when you do a deep dive that you're not capturing everything because of these configuration issues. There's also data entry issues. We're all human. We all make mistakes. Your staff and providers could have the best of intentions for getting the data in the right spot, but just note that especially with EHR-based reporting, these quality measures are looking for very specific information in very specific data fields. If your clinicians, your staff are not properly utilizing those data fields, it's going to affect that quality data score. So again, do that deep dive and ensure that if a patient is not appearing in the numerator but is in the denominator, look at why. You may find that it was really just a data entry issue, that you didn't get numerator credit because a medical assistant accidentally put some information in a free text field versus what's called a structured data field, and it's kind of broken the quality measure in that way. So only after you've done those 3 checks, doing that deep dive, can you really trust the data and then really start working on what could be deemed quality issues. So I mentioned this a little bit. I'm going to expand upon it now also. That data submission type really, really, really matters under the quality performance category. Don't take this lightly. This one decision on how you're going to get the data to CMS could make or break your quality category score and could mean the difference between a positive adjustment or a penalty just by routing the data a different way to CMS. I'm going to talk about that more on the next slide. There's also varying costs with the different data submission types. Claims-based reporting and login and upload is free. Your vendor is invariably going to charge you. The vendors love to nickel and dime their clients to death, and they're going to find every way to put an upcharge on something. Submitting that data on your behalf is often one of those ways. Registries, while they can be great options for those specialists, are never free, so you have to kind of look at the cost as well. And then it's really due to the benchmarks on why those submission types matter, and the next slide is going to expand upon that. I'm also going to talk at length about topped-out measures and then topped-out capped measures. So a topped-out measure denotes a measure where there is no longer significant difference between the highest performers and the lowest performers on that measure. Really, everybody is doing really well on it now. We will see, if you look at the list of 257 measures right now, you're going to see that the majority of them are actually topped out. So CMS has some work to do in terms of cleaning up these measures, getting rid of topped out ones. Again, if there's no longer significant difference between the highest performers and lowest performers, that measure is no longer a good measure. So now they instituted this concept of a topped out measure last year, and we see that carried through into 2019 as well. If a measure has been topped out long enough, they are now starting to cap it, where you can no longer earn 10 points for perfect performance, you can earn a maximum of 7 points. So if you are reporting on a lot of topped out capped measures, you could significantly hurt your quality category score. So you're going to want to avoid those capped measures if you can. And I'll expand upon this in just a couple slides from now as well. So back to that, the benchmarks issue. So some measures, some of the quality measures can be reported through various submission types. We've got an example right here for measure ID 110, preventative care and screening, influenza immunization. This one can be submitted via claims, via your EHR, or via a registry. So look at the very top for this example, a performance rate of 62. So we're going to look at claims-based reporting first, but just note that each one of these submission types gets its own benchmark. There is a wide variation in the data being submitted through each of these submission types. So CMS has had to create a benchmark for claims-based reporting, a different benchmark for EHR-based reporting, and a different benchmark for registry reporting. So what that creates is a situation where the exact same performance rate can earn very different scores. Let's look at claims-based reporting first. We're going to follow the green numbers. You got the formula there for how they award the points relative to that performance. You don't pay too much attention to that, but just look at that performance rate of 62, follow it down to the grid here, and you can see that a 62 is going to fall somewhere in decile 5. I mean, you're going to get 5 point something for that measure. As it turns out, this performance rate against this benchmark would earn a clinician 5.96 points for that measure. And look at EHR-based reporting. So that exact same performance rate. So quality care has not changed at all. You've done exactly the same thing. You're just choosing a different path to get the quality data to CMS. If we compare a performance rate of 62 against the EHR benchmark, suddenly you're in the 8th decile. So that same performance rate can earn you 8.9 points. Registry then is somewhere in the middle. That gets a different benchmark, and in this example is going to award 6.64 points for that exact same performance rate. So multiply that 6 times over, and you can see that you can earn a much greater quality category score just because you've chosen maybe to report via your EHR versus claims-based reporting. So I can't stress this enough. Look at those submission types and ensure that the way you're routing it to CMS is the way that's going to earn you the best quality category score. Back to that topped-out measure issue, I would urge you to avoid topped-out measures if you can. It's getting harder and harder to do so, but I'll explain why this is detrimental. So many measures are topped out, but have not yet been capped at 7 points. So you can see as a measure is topped out, the top grid here, we start to lose decile scoring options. So look at that very first one, measure ID 5, near perfection, a performance rate of 99.99%, which is exceptional, is still only going to earn you a maximum of 5 points in that measure. You'd have to be at absolute perfection, at 100% to earn the full 10 points for that measure. So you're going to jump from 5 to 10. So one tiny mistake in one patient for that one measure is going to cut 5 points out of that quality measure. So topped-out measures are kind of tough because of those limited scoring options. So that's a good reason to avoid them. But it gets a little bit more complex, unfortunately. A lot of the measures, while they're not topped out, are starting to be topped out. And even though it's not topped out, scoring options may still be limited. Here's a couple of examples here on the bottom grid, where we've got two different quality measures here that are not topped out, but they're getting there. And so you can see in that first one, deciles 7, 8, and 9 are already missing, even though it hasn't yet been deemed as a topped out measure. So again, this is a very difficult landscape, but that measure selection can make all the difference. And if you can avoid topped out measures, I would suggest you do so. It's getting harder and harder with each passing year. And so you're invariably going to have to pick them, but really limit those topped out measures. And if you can avoid the topped out capped ones, definitely do that, because that can make a huge swing in that quality category score. All right, moving on to cost performance category. It's worth 15% of that MIPS final score. There's no reporting requirements, as I mentioned. It all comes from administrative claims. There are 10 measures this year that are going to be looked at for you if they can. We have the Medicare spending per beneficiary, otherwise known as the MSPB. We also have the TPCC, or total per capita cost measure, and then there's new eight episode-based measures that are new to this year, and I'll list those on the next slide. So in order to be scored on a cost measure, the individual has to have enough attributed cases to meet or exceed the case minimum for that particular cost measure. So not everybody's going to be measured on all 10 of these, and really I fail to see how any one clinician could be scored on all 10 of these. So if any of the cost measures apply to a clinician or a group, that measure or measures will be used to calculate the entire cost category score. If no cost measures apply to a clinician, which does definitely happen, the category weight will be shifted to quality. So we'll see that that 15% that is right now allocated to cost, if they can't score you in the cost category, that 15% is going to be added to the weight of the cost of the quality category instead. A couple of resources there to get you started. Here are the 8 episode-based measures that are being used. So if none of these are going to apply to you, you won't see these be used to calculate your cost category score. I've got some additional category resources for you there at the bottom. If you want to unpack this, I suggest you go to all 4 of those resources and really read through them. It will give you a wealth of information on the cost category. Now that I've talked about quality and cost categories, before we go into PI and improvement activities, I want to pause and talk about a new scoring option that CMS is bringing in for 2019 that I think is going to be a fantastic option for a lot of you. It's called facility-based scoring. So it's an option now for this year, beginning this year, for clinicians or groups who meet certain criteria. So it allows for these clinicians or groups to have their quality and cost category scores to be based on the hospitals at which they work instead of the activity coming out of their own tin. So hospital-based clinicians find that they're often doing most or all of their charting in the hospital system, and that's in a different tin. So you can't really get at that data and pull it into your tin to get a score, a quality score coming out of your tax ID. So this is a great option for those facility-based people, those hospital-based clinicians. If you are in an ACO, just note that this is not an option for you because you are locked into that ACO's model, into that MIPS APM's scoring. So even if you are a facility-based clinician, if you are participating in an ACO, this is not going to apply to you. So a facility-based clinician is one who furnishes 75% or more of their covered professional services from place of service 21, 22, or 23. And you have to have at least one single claim coming out of place of service 21. Then a group could also be noted as a facility-based group if 75% or more of the eligible clinicians within that tin are eligible at the individual level. So that attribution then, facility-based clinician, gets attributed to the hospital where they provide the most services. So if you are working at 2 different hospital groups, the one that you provide the most services to would be where your facility-based score would come from. And sort of the same thing with the group, although they're going to look individually at where the most of those facility-based clinicians are being attributed, and then the group would be attributed to that facility as well. If CMS is unable to identify a facility with what's called the hospital value-based purchasing score, then you would not be able to use this for your MIPS final score. So that's the program that the hospital participates in that measures their quality and cost. So if your hospital that you're attributed to is not generating a VBP score, then this would also not be an option for you. But what's interesting is that CMS is going to automatically apply this new scoring option to anyone that they can do it for. So it's an automatic thing. You don't even have to opt into this new option. CMS is going to try and score you on the facility score if they can. So no submission requirements then are needed for an individual clinician to be scored this way. But if a group would like to be scored at the group level for facility-based scoring, you're going to have to signify to CMS in some way that you want to be measured at the group level, and you would do that through the other performance categories, the improvement activities or promoting interoperability performance categories. If you submit that data at the group level, then CMS will know that you are looking to be scored in this new option at the group level as well. So for facility-based measurement, the measure set for the fiscal year hospital VBP program is what is going to be used for this. But there's a little bit of a timing issue here that makes it a little bit wonky. So for example, for the 2019 MIPS performance period, for this year, the measures used would be those for the 2020 hospital VBP program. That doesn't start until the new fiscal year starts. So there's not a lot of overlap here. So what would be used for you for 2019 would actually be the hospital's performance from October 1st, 2019 through September 30th of 2020. So I think this is going to cause a timing delay for your final feedback reports. Because if they can't measure you in the VBP program until this program ends in September 30th of 2020, you're not going to get your final reports until after they can pull that data in and score you in this. So it'll be interesting to see next year what this is going to do to the timing of those final feedback reports. There is a facility-based preview available right now. If you go to the link there, the qpp.cms.gov/login. Again, that's the same site you're going to submit data. That's the same place you go to to look at your eligibility. There's also something called a facility-based preview. That's going to give you some insight on your facility-based clinicians. It's not going to give you your actual facility-based score, but it's going to look back in time and say that if we could have scored your facility-based clinician in this way, this is what that score would have been in the past. So that can give you some great insight into how your clinicians would do in this performance year as well. There's a fact sheet there that I would recommend you pick up as well. So the quality and cost performance category scores then for facility-based clinicians are based on how well the clinician's hospital did. And some hospitals do not receive a score for that given year as well. And again, due to the timing, it's a little bit, you're taking a little bit of a chance if you're only going to rely on that facility-based scoring. I honestly wouldn't suggest that anyone just do that this year because there's no way to pick up a crystal ball and know how your hospital is going to do, especially because of the mismatch in those performance periods, where the VBP program that's going to get used for your 2019 is going to extend all the way into the first 9 months of 2020. So if they can't score you in the facility-based scoring, then if you're relying on that, you're going to be left high and dry. So what's interesting though is that look at that box at the bottom there, because CMS wants you to be successful. If a clinician who is facility-based decides to also submit their own practice level data, CMS is going to look at both the facility-based score and what came the data that you submitted independently, and are going to award that clinician with the better of the two. So my advice would be to certainly look to this facility-based score what I've been seeing when I've been looking at some other folks at their facility-based preview, I think it's going to be a fantastic option for them to get insanely good quality and cost category scores. But don't just rely on that. Submit your own quality data if you can, so that CMS will take the better of the two. And then in that way, if your hospital messes up and they forget to submit their data or they score really poorly, you're not going to take a hit in the quality and cost categories there. So submit both ways, and CMS is going to take the better of the two. Improvement activities. 15% of the MIPS final score. We've got 118 activities to choose from this year. You don't have to pick new ones from year to year. So any previously implemented activities, including ones that you attested to last year, can be used again year after year. Each activity is worth an assigned weight. They're either medium weight activities or high weight, worth 10 points or 20 points, unless you're in a small practice. So, or one of the other special statuses listed on the screen there. If you're one of those special statuses or that small practice, the point doubles or the point values are doubled. So a medium weight is worth 20 points and a high weight is worth 40 points. You're just going to select yes to having when you attest to this, to saying that you had it implemented for at least 90 continuous days this year. And to max out in this category, you want to ensure that you are earning 40 points within the category. So a small practice could attest to a single high weight activity and they would get full credit in this category. All right, we're going to roll into the PI performance category. It is worth 25% of that MIPS final score. You must be on your 2015 edition of your EHR, otherwise known as CERT. It's all performance-based scoring this year at the individual measure level. So that's a major change. In previous years, we had a base score and a performance score. They've gotten rid of that base score. So everything is now relies strictly on the performance of those measures. I suspect we're going to see everybody take a little bit of a hit from last year to this year in this category because of the way they have changed the score. So while this category is based off the former meaningful use program, it is now vastly different from that program. They've stripped away a lot of the measures and objectives. It's scored very differently. If you're still participating in the meaningful use program on the Medicaid side, you're participating in this category as well, you are going to see that there is very little overlap now between these two programs. What we have left here for objectives are e-prescribing, health information exchange, provider to patient exchange, and then public health and clinical data exchange. Here are the measures that are contained within those 4 objectives and the maximum points you can earn for each one of them. Again, you want to participate in a way that's going to maximize this category. Note that the SRA, Security Risk Analysis, it used to be its own measure that earned points. It is not a measure that earns points. However, it is still that mandatory annual requirement. So if you don't do your SRA in 2019, you are going to earn 0 points in the PI category, regardless of how well you do on these measures. So to earn a score in the performance category, you got to use the 2015 edition of your CERT and report on a minimum of 90 days. There's 3 questions that you have to attest yes to get through this. 2 of them related to information blocking. The last one indicating that your annual security risk analysis was completed. And then you have to report on all of the measures under each of those objectives or claim the applicable exclusion. You're going to be scored based on that performance, or for the few that are yes, no, you just attest yes to, let's say, the active engagement with a registry, and then you'd earn those points. And then the scores for each of those measures are added together to calculate that overall quality category score. There is some reweighting that's available, both there's automatic reweighting as well as application-based reweighting. Clinicians who qualify for that reweighting, whether it's automatic or application-based, will see that 25% that is right now. This category is going to contribute 25% to that MIPS final score. PI would be worth 0%, and we'd see that 25% shift over to quality, making that worth 70 instead. So the automatic reweighting really happens for a few of the special statuses and everybody except the MDs and DOs, or except the physicians, I should say. So all those other provider types don't have to submit PI data. They get a pass on it, so we get that automatic reweighting. However, it sometimes makes sense to override that reweighting. So let's say you have a nurse practitioner in your practice. He or she would not have to submit PI data, but a lot of these nurse practitioners have participated in meaningful use in the past, and we traditionally see them doing very well. If they've kept those workflows up and running, you'll find that they can still do really well in the PI category. You can override this automatic reweighting by just submitting PI data for that nurse practitioner. That will signal CMS to say, oh, they want to override the reweighting that we've already applied, so we're going to pull that 25% back and put it in the PI category. So don't necessarily just rely on this reweighting. You may find that it's advantageous to submit PI data anyway. There's an application that you can fill out as well, including for small practices. So if you are 15 or fewer clinicians and you don't have an EHR, you're going to want to put in that application to get reweighted, so you don't take a 0 in the PI category, get those points moved over to the quality category. The application for that is not available yet. We will see that probably within the next couple of months for 2019, and then we will have until the end of the year to get that application. It's a very, very quick process that gets approved very, very quickly as well. So there's usually, often a less than a day turnaround time for the 5 minutes it's going to take you to fill out that application. So what's it all mean once you get through all these performance categories? How does it determine that payment adjustment? So again, you're building that MIPS final score. That final score is going to be compared to the performance threshold, which changes each year. This year, in 2019, it is 30 points. So you want to make sure that your MIPS final score is at least 30 points. And anything above that then is going to earn you a positive adjustment. There's an additional performance threshold for exceptional performers. That is set at 75 points. That's really where you want to be. You really want to be shooting for at least 75 points so that you can get some additional monies allocated to you. So CMS then compares your MIPS final score to that performance threshold and adjusts your payments accordingly. This year, the payment adjustment is plus or minus 7%. But remember, I mentioned earlier that this is a budget neutral program. So what that means is those that are getting penalized are paying for those that are getting incentivized. So if you're getting a positive bump in your reimbursements because of this program, know that that is because somebody else has been penalized and their monies are now your monies. But to ensure that budget neutrality, the payment adjustments are likely to be increased or decreased by something CMS calls the scaling factor. The amount of the scaling factor depends on the distribution of those final scores. So if we don't have enough people getting penalized, we're not going to see that max top-end reimbursement bump. So for example, in year one, what was supposed to be as much as a 4% bump for those top performers got scaled way back because it was so easy to avoid the penalty. And that top-end max increase then was scaled all the way back to 1.88%. We're going to see the same thing happen for last year's performance. That was plus or minus 5%. There's no way anybody's going to see a plus 5% bump. It's going to be scaled back, probably somewhere in the low 2% will be the max. I'm not sure where we'll fall. We'll see when we get those final reports what that means. But as the performance threshold increases, so will the number of penalized participants. And that's an important component. Once we get through the transition years, we're going to see a lot more people take penalties, and that's when we're going to see those huge top-end gains, and we'll start to really see the return on investment in this program. Performance threshold and payment adjustments. This gives you that breakdown depending on where your MIPS final score is compared to that benchmark and kind of what it's going to mean. So that performance threshold is incrementally increased each program year right now. CMS is setting that for us. It started out at 3 points. Last year it was 15 points. This year it's 30 points. Next year will probably be 40, maybe 50 points. We'll see. But after we get through what's called the transition years, which take us through 2021, as of 2022, that performance threshold becomes the mean or median of the prior year's performance across the entire MIPS landscape. So what this means is when we get to 2022, your minimum performance threshold is probably going to be somewhere in the range of 70 to 85 points. So as of 2022, participants are going to need to achieve scores that right now, today, this year, are considered exceptional performance in order to just avoid a penalty. So if you're taking the easy way out right now, through these transition years, you're not doing yourself any favor. When in these years, when the threshold is relatively low, shoot for the moon. Do the best you can, because that best in a couple of years from now is going to be your minimum. And if you don't do what is considered exceptional today, a few years from now, you're going to take a massive penalty. Don't be one of those. So through these transition years, shoot for the moon, do the best you can, so that when that performance threshold skyrockets all the way up to 70 or 85 points, you're still at least at a neutral point, hopefully a positive point, and not taking a penalty. I've got a getting started checklist here. I see I am, as usual, running a little long, so you can circle back to that at your leisure. If you are participating in this program and you're struggling at all, just note that you don't have to do that alone. There is free help for everybody who wants it, whether you're a small practice or a large practice. If you're in an ACO, it doesn't matter. Anyone who is participating in this program, there is free CMS-funded help for everybody. If you're a small practice, you get to work with Altarum. If you're part of our greater 7-state collaborative that we are working with, a bunch of awesome partner organizations in 6 other states, you would still be participating through our network across all those 7 states if you're in that small practice. If you're in a large practice, there is free help for you too. If you're not sure who is supposed to be helping you free, you can go to the qppresourcecenter.org. That is our web portal that we have created to support clinicians, and click that Join Now button and interface with us. We can help you to kind of route you. If it's not us that's going to help you, we'll get you to the appropriate person no matter what state you're in. Before I roll into questions, I have a quick poll that I'm going to launch here. So this is something as CMS is paying us to be out there helping you, and they want to know how we're doing when we're out there helping you. So if you would please take a moment, I greatly appreciate, and tell me how I did today in conveying all of this information, with 5 being very satisfied, 1 being very dissatisfied. Again, we have to report this information to CMS so they can keep tabs on how well we're doing. I'll leave this open for just another sec before I jump over to the handful of questions I have gotten. All right, thank you to anyone who voted there. And with that, we'll jump over to questions. If you have a question, if we can help you in any way, shape, or form, please don't hesitate to reach out to me or to our greater collective team at the qppinfo@altarum.org. Give us a call, go to the QPP Resource Center and join. You can email me directly, you can call me directly. If you've got questions, we've got the answers, or we will find the answers for you. So do not struggle on your own. Use us. CMS is paying us to be out there helping you, and we want to ensure that you have absolutely everything you need to be successful in this program. I've had a handful of questions coming in. Let me get through these real quick. If we submit data for quality and get a facility-based score, will they publish the quality scores we submit on Physician Compare? What we'll get on Physician Compare will be the better of the two. So if you are a facility-based clinician and you can be scored that way, but you also submit the data independently, whichever of the two is best is what's going to appear on that Physician Compare website. Regarding the reweighting, if we submit data as an ACO, which is a group submission by 10, can we not submit data for all or certain PA and Ps and all the rest, or do we have to submit all the data from all the classes? I know we can do the reweighting if we submit individually. Great question. So if you're in an ACO, the only performance category that you have to submit data on independently at the TIN level is your promoting interoperability. You have that option this year to submit that data as individuals or as a group. If you choose to submit as individuals, you are only going to submit the data for your MIPS eligible clinician types. If you have PAs in there or NPs that would normally be reweighted, you can still submit that data and it's going to get used. So you can still kind of override that reweighting if you want your mid-level providers to contribute to that PI score for your 10. So you can override that reweighting and submit that data. You do not have to. So if they are being reweighted and you would like to continue with that reweighting, then you would only submit the data for those that are not reweighted. However, if you submit at the group level, you must include data on all clinicians who have information that you can report on. So in that model, all that reweighting goes out the window. So if you're in that ACO and you're submitting as a group, you are going to submit all data from all clinicians. So even those that would normally have qualified for that reweighting, if they were submitting individually, you have to submit that data. So that is a good way to ensure that you are providing the best PI quality score or PI category score to contribute to that ACO score. Look at the two different ways that you can report. Either report individually if that's going to provide you the best PI score, or report at the group level if that's what's going to earn you the best PI score. Because again, as a responsible ACO member, you want to ensure that you are submitting the best data that you can. Last question. Any thoughts on the top end percent would be? It won't be 7%, but is CMS giving any insight? Not really any hard evidence on what we're going to see here. I suspect, again, for 2018, it's probably going to be in the low 2%. I'm hoping for 2019, we're going to get somewhere over 3%. Again, there's really no way to know until we see how people are doing. But I think over time, as that threshold increases, we're going to see more people getting penalized, and we'll start to see those better and better top-end reimbursements. But my guess right now is at best, instead of a plus 7%, will probably be around a plus 3% or something like that for this year. That is all the questions I have. If you have any more questions after we are done today, again, please don't hesitate to reach out. We are here and we really want to help you be successful in this program. So let us help you by pummeling us with every question you can possibly come up with. Thank you all for joining me today. I hope you learned some valuable information. I look forward to seeing you on future webinar broadcasts. And with that, have a great day.